Thank you for joining us on this beautiful Thursday. My name is Thiv. I am the CEO and co-founder of Hera, and I'm super excited about today's Ask Me Anything. We had done this, I think, a year ago, right, Dr. Sun, and got great results there. And this time we wanted to do something different where we have both an REI and a urologist together and have conversations that are very specific and targeted around fertility, male fertility, you name it. And so we've already gotten a bunch of questions to start. But as we're going along, if there's questions you guys have, please put it into the comments. We'll be able to go through them. We'll try to get through all of the questions that we have. But if we don't, we'll try to get back to it afterwards. But before we get started, would love for both docs to introduce themselves. Maybe Dr. Sun, you can start.
Yeah, sure. Andrew Sun. I'm a male infertility specialist urologist. I practice in Arlington, Texas, kind of between Dallas and Fort Worth. Run the Men's Health Center inside of a large urology group. So we focus on hormone management for men, infertility, and also, erectile dysfunction, sexual dysfunction, and these kinds of things, as that also plays a role in fertility. And yeah, that's me.
Hi, I'm Dr. Noorhasan. I'm a fertility specialist here in the Dallas-Fort Worth area, and complementary to Dr. Sun, I trained on the female aspect. So I did an OBGYN residency as a gynecologist, and then a fellowship in reproductive endocrinology and infertility. I do essentially IVF and egg freezing, and Dr. Sun and I are very complementary to each other, where I see and do mostly the female aspect, and he does the male. But we combine together to do the IVF and fertility treatments and bring information for both the male and female as to how they both can improve their eggs and sperm to get better embryos, and ultimately the final results, taking a baby home. So I'm pretty excited to be part of this. Thank you for the invite.
Now, awesome, thank you. And let's get right into it because we've gotten a bunch of questions. So the first question I wanted to ask you guys, and feel free, one or the other, or both of you guys answer it. The first one is, how significant is abnormal morphology, 2% or 0% for natural conception versus IVF? Is it often over or underweighted in a diagnosis?
So, it's definitely, of the big factors that we look at, concentration, motility, that kind of thing, morphology is, at least for us, probably the one that we generally care about the least. Not to say that it's not important, but, if you have good motility and good numbers and overall, and like the morphology is a 3, where the absolute cutoff is a 4, like that's probably not necessarily going to make like the biggest impact. Especially because, as you probably know, most people know, like with semen analyses, rarely do we have a direct intervention for like each individual factor, right? There's not like, oh, I have low concentration, do X. I have low morphology, do Y. It's much more sort of broad and general than that. And so when we're talking to guys about their semen analysis, of course, everything's important, but for us, it's not quite as the most important thing. I don't know about when you guys look at it.
Yeah, I agree with you, Dr. Sun. I think we look at the whole aspect as well. It's not just the morphology. So the concentration or count is important, motility is important, the morphology is important. And I really do feel like seeing the big picture, having a Kruger score. So just for everyone, we follow the WHO 6th edition 2021 parameters. So morphology, Kruger strict morphology of 4% or higher is what we're looking for. And I agree with Dr. Sun. If it's a 3%, but everything else looks good, the motility looks good, the concentration looks good, we're not going to worry too much about that 3% morphology. But if the morphology is persistently 0%, 0%, 0%, and we're seeing that in light of low sperm count, low sperm motility, then perhaps maybe we would be discussing something differently. So again, I agree with Dr. Sun. It's looking at that big picture, not just that one specific number.
Perfect. Thank you for that answer. The next one we have is around DNA fragmentation. This has been a popular test now I've seen more and more of. And so what is the best lifestyle changes and treatments to improve DNA fragmentation when there's no identifiable root cause like varicocele or inflammation?
Yeah, sure. One of the themes in general when we're talking about male infertility and like interventions upon the semen analysis that you'll find is that it's very hand wavy and generalized. The science in the fertility world is just in the male fertility side is just not that good. We have this semen analysis with these numbers, and they generally correlate to things, but there's much that we wish for in terms of like really getting into the nitty gritty about like the detailed science of this. And so DNA fragmentation is one of those things. Obviously, if you have lots of DNA fragmentation, we think that would be associated with more either difficulty conceiving or early miscarriage or pregnancy loss. And if you think about DNA fragmentation as damage, and damage as occurring from what we call oxidative stress, or basically like stress along the sperm as they're being produced, then anything that seems like it would reduce that would be a good thing. I mostly just tell my patients, like, anything that it sounds reasonably healthy, probably should do that. And if it sounds unhealthy, don't do that, because patients are always asking like, hey, how many drinks can I have? And how many cigarettes can I smoke? And my answer is, does that sound healthy? Like, if it doesn't sound healthy, you probably shouldn't do any of it. Ideally, in the real world, you got to do what you got to do, I guess. But, and so in terms of like lifestyle changes, don't do bad things. Smoking, that's obviously very like oxidative stress or, inflammatory, right? Extra heat is not usually good. That's the one thing. Like, I like saunas, but sperm don't like saunas. So definitely, stay out of that. And then, in terms of like preparing for a semen analysis, there's some idea that the earlier you get the sperm, or the fresher the sperm is, to, per se, the less time that sperm has been around to accumulate this sort of DNA damage. And so, frequent masturbation, or basically like ejaculating a bunch of times before giving a semen analysis for use, whether that's IUI or IVF, you're trying to basically flush the pipes, so to speak, and get the fresh guys going so that they don't have enough time to accumulate that DNA damage. That's also a strategy that you could, potentially use.
Yes, I agree with all those things. With lifestyle, cutting out heat exposure, just like you said, sauna, hot tubs. I know working out is great for men, and then they want to sit in the hot tub, but sperm doesn't like that. So for men, the sperm or the testicles sit outside the body because they need a cooler environment for spermatogenesis, for the sperm to grow. For women, our ovaries sit inside the body, and our ovaries can tolerate high body temperature. So for men, having that cooler environment is so important. And I absolutely agree as well. Cutting out substance usage is very important. One of the other things I talk to patients about is getting more antioxidants. So we talk about starting vitamins. Just a multivitamin a day is great. Extra zinc, extra selenium, extra coenzyme Q10, also very good. I also stress with them healthy lifestyle. And there's so many diets out there, and we all get trapped with which diet should I follow, and what's the right thing, and am I doing the right thing? And sometimes we feel like a failure because we should be following one diet or the other. And the reality is just diet in moderation. Try to stay away from processed food. So anything that's processed, where you read the ingredients section on a box or container, and there's some long chemical name in there and you don't understand what that is, that's probably not something that's good for you. It's probably very processed. So staying away from processed foods is a big thing that I tell patients, as well as trying to cut out carbs as much as we can to our ability for all of our cells to tolerate sugars becomes less and less as we advance in age, and our insulin resistance goes up with age. And so cutting out sugars is super important. And then from the treatment standpoint, just like Dr. Sun said, frequent masturbation or ejaculation prior to giving us that sample for the IUI is very important. That way we get a fresher sample, a sample that's not been sitting in the system or in the pipes being exposed to oxidation for a long time. So giving us that fresher sample, and as well as in some severe cases, Dr. Sun and I have decided that testing may be important, so testicular sperm extraction. Many times I would refer the male patient to Dr. Sun for that TESI. So there are many aspects of that sperm DNA fragmentation. And the thing is, the technology has gotten so far ahead of us where we're doing all this testing. We want to know, why is it working? Let's try this, let's do this. And then we get the results. And it's not a black and white decision where, okay, with this result, I have to do this or this. And I think it's a combination of all those things, the lifestyle changes, the frequent ejaculation prior to the sample that you give to us, or in very severe cases, the testicular sperm extraction. I think all those things are very important to decrease the oxidative stress to the sperm when we see it. And Dr. Sun, I would love for you to tell some of our listeners about the testicular sperm extraction and how important that is.
Absolutely. You know, we don't have that many surgeries in the male infertility world, right? We can basically pluck the sperm out of the testicle. We can do vasectomy reversals in case that's the cause, and we can fix varicoceles. And those are kind of the big three that we can do. Testicular sperm extraction, there's many different names of it, whether it's a TESI, a PACE, all these little 4-letter acronyms. They're basically all versions of the same thing. Even a micro-TESI is not really dissimilar from a TESI. It's a very, very detailed TESI under a microscope, right? And at the end of the day, you're doing one thing with all of these surgeries, which is you are directly extracting sperm if they are available from the testicle or the epididymis, as the case may be. It's a pretty quick procedure, generally speaking, 30, 45 minutes. They can be done under local, but the really more invasive ones, like you wouldn't necessarily want to be awake for this. And essentially we go into either one testicle or both, and we make a little incision and we take out some tubules, and hopefully there's some sperm in there. Now, it would be a long discussion about every different possible circumstance in which you would do this, but most commonly would be non-obstructive azoospermia, meaning they're not blocked, but they have no sperm on ejaculation. Or, you know, post vasectomy, yes, we can do a vasectomy reversal, but sometimes it's easier to just get the sperm and there you go. And then in this type of situation would be a little bit more unique, but we also do this where they do ejaculate sperm, but you're worried that the sperm that they ejaculate has high DNA frag. And so if you get the earliest sperm straight out of the testicle, then you may have, and there's some data to support this, you may have less DNA fragmentation and greater success. So, you know, it's not a long procedure. We basically make a tiny incision, extract the sperm, sew it up, and you go home, ice pack on the scrotum and whatnot. But it is fairly heavily utilized because a lot of times, for a variety of different reasons, we have to go straight to the source and get to the sperm, either because we can't find any on the ejaculation or otherwise.
Yeah, and this is, you're absolutely right with the DNA fragmentation, getting the sperm directly from the testicle. In the really severe cases of very abnormal fragmented DNA, sometimes that's important. And the way how I love to tell people this is, it's like you're going directly to the factory and getting the sperm directly from the factory, and it decreases, or that sperm is less likely to be exposed to all that oxidative stress that the sperm experiences as it's in the male reproductive system. So this is great.
Yeah.
Just to follow up on that, there was a question that came in around non-obstructive azoospermia. And so I just wanted to round this out here. Is in men with non-obstructive azoospermia, what biological signals would you most want measured to improve micro-TESI decision-making?
Yeah, this comes up a lot, and this is where I really wish that we had better data, because, you know, the honest truth is sitting in front of any non-obstructive azo person, you're basically pulling a number out of thin air when you're making up a percentage chance. Like, nobody really has good data on this, and many people will criticize the data that we do have. For example, a lot of this is done at Cornell and other places, but if you micro-TESI every patient, including those who didn't need a micro-TESI, then your micro-TESI success numbers look a lot better than they probably actually are, right? If the first step is to decide, like, who really needs a micro-TESI, and then there are some genetic, you know, things. What I tell patients, you know, when we're dealing with non-obstructive azo is basically like, you either genetically can't make it, or you make very, very few and we can find it. The problem is there may be 50, 60 different gene things that could happen that cause you to be incapable of making sperm. And we have tests for two, right? We have a karyotype and we have a Y chromosome microdeletion assay. There's there's several different types of Y chromosome deletion, so you could call that 4. But really, most of the times, those tests come back normal anyway. We just don't have a test for like the other possible hundreds of different gene flips that could be happening that would cause this. There's a variety of other things. There's Sertoli cell only, there's maturation arrest, there's all these different sort of pathological diagnoses, meaning like they would see it on a biopsy specimen. But at the end of the day, what matters to the patient is, am I going to get sperm or not? And is that sperm going to be useful for IVF? The second thing I always try to tell people is that, like, I can quote you a semi-made up number for the likelihood of finding sperm, but we should not conflate that number with the percentage chance that you will have a baby, right? That's finding sperm is step 1 of like a 10-step process, and we still have to make it through each step after that. So I try to be hopeful, but I also try to be fairly realistic sometimes, Now, in terms of like Sertoli cell function, the surrogate marker for that is FSH, right? The higher, so the brain produces LH and FSH. LH tells your testicles to make testosterone. FSH tells your testicles to make sperm. They make enough, they have a negative signal, it kind of balances out. Normal patients should have an FSH and LH level of, let's say, 2 to 5, testosterone of 4 to 500, and a normal sperm count. So the higher the FSH is, the more this person's body is telling you that their brain is essentially screaming at the testicles to make sperm, and the testicles aren't doing it. And there is definitely, although it's not like at some number the percentage becomes this or that, but there's definitely a general correlation between the higher the FSH is in a man and the lower the likelihood you're going to find sperm, right? So I'm much happier when I see azoospermia and the FSH and LH are like 8 than when I see an FSH that's like 40, right? That's not impossible, but it definitely does decrease the chances. We don't have that. I mean, testicular volume is used as like a surrogate size. As you can imagine, there's some not perfectness to that, the sort of feel of it. I mean, those of us that do this a lot, like, we've felt a lot of testicles. So, some testicles feel more plump than others, and some testicles feel more soft. And that's like kind of a factor, but they're all just trying to get you an idea of like what you think, if you think this is going to work or not. But at the end of the day, you don't really ever know until you get in there, and what we do sometimes try to sort of load the boat ahead of time. So we give them a bunch of very empiric medications to try and crank up as much intratesticular testosterone as possible. And that might be increasing FSH and LH artificially. That might be blocking estrogen conversion artificially, doing all of this stuff to try and create the happiest environment inside the testicle. And then you go hunting, and then, whatever happens, basically, depending on what you're going to find. So we don't have, the answer to the question is basically, these little kind of predictive factors are helpful when we're counseling patients, but at the end of the day, it's still just a hunting game and see what happens kind of thing. And it's a difficult decision to make because, it's a surgery. It's not a completely easy process to go through.
Just to follow up on that, there was a question around non-obstructive azoospermia, but do you use flow cytometry to analyze the stage of spermatogenic development in NOA cases? Do you consider it a useful tool to monitor for recovery or improvement of spermatogenesis during treatment?
I'll ask Dr. Noorhasan that question. Do you guys use that? You guys have a much bigger lab than I do.
Yeah, we don't use it for that. No. It sounds like this guy he's done several flow cytometry semen analysis since it's varicocele. Yeah, we don't use it.
Yeah, I don't either. That's sounds like a fairly advanced tool there, but for like at the end of the day, like when I'm doing a varicocelectomy or not, it's kind of also like, well, guy has a varicocele, and we have a reasonable time frame to expect improvement, right? Like if a guy comes in and him and his partner are both 22 and he has a big varicocele and impaired semen parameters, I'll definitely recommend fixing that. If the guy is, well, I guess it doesn't matter what the guy's age is. If the woman is like 39, I'm probably going to say, let's just take what we got and go ahead and do IVF, because it can take like a year to get the full improvement out of a varicocele repair, you have to first heal from the surgery, then you have to make new generations of sperm, which takes 90 days, and then they can keep continuing to get better from there. That may not be worth it if you already have sperm. Now, if it's an azo patient, I guess it's something to do. And then we usually take a biopsy of the testicle at the time of the varicocele repair and sort of see if they're early maturation arrests, late maturation arrests, or totally cell only, things like that. But ultimately, I think that if you had to keep monitoring for improvement, if you're talking about an azo patient, then you have to keep taking biopsies, which I'm not generally going to do. And if it's a patient who has sperm in the ejaculate, then you probably just use it once you get some to do IVF with,
Yeah, I agree with you in terms of the varicocele repairs. Exactly. If you have a 21-year-old and you have time, you can do the surgery and you have large varicoceles, you can do the surgery and you have time to watch it recover. But then if the partner is older, really we're talking about IVF, and you may be doing some modifications like hormonal treatments, but really trying to get them to IVF as soon as possible.
And I think that's a very important point, like that we work together very closely. And there's a lot of times where I have a guy come in and he's got, some stuff going on, but like, I sort of ask the question, like, how old is your wife? And then when the answer is like 37, 38, 41, I'm like, look, I can play around with stuff on with medications and do stuff. And maybe I change things like in a 5-10% in either direction, but like, we just kind of need to go towards this, because again, much of my counseling, and I talk about this in general, fertility is one of the only fields, if not the only field in medicine, where you have to simultaneously consider two people, right? And, if I just played with the sperm forever, and not considered what's happening over there, that's not going to work out. And we historically have seen that women definitely bear the burden of the infertility care. And I would say I used to see a lot more guys who they've been trying for 3 years and their wife has been evaluated all the way and they've never had a semen analysis, right? And so now finally, thanks to companies like Hera and others, men are getting semen analyses earlier, which is great, because why not check both partners from the outset? It was always very sad to see this 3 years of wasted time when the woman's been through all of this testing and the guy never had a semen analysis, and lo and behold, he has azoospermia. I'm like, well, we could have known that 3 years ago,
And that's so important that you said that. So getting both people tested is super important. And at that new patient visit, we give them a battery of testing. And sometimes they look at me like, why do I have to do everything here? Because there's so many aspects of fertility. There's the eggs, there's the reproductive system, and then the sperm. And the sperm is very important. The sperm contributes to that embryo and to creating another person, a fetus, and a live birth. And so the sperm is very important. And I'm really glad companies like Hera have started up and getting men the knowledge and education they need about male fertility and getting them to testing sooner than later.
Awesome. Man, time is really flying by. I know we had planned for only for 30 minutes. Is it okay if we go a little bit over, guys?
Yeah, I'm good.
And we might not get through all of the questions, but there's some really good ones that are coming out. I think one consistently I'm seeing is around FSH. And so there's a two-parter here. I'm just going to post it here. All right. Let me see if I can show it there. All right. So the first part is around, what do elevated FSH levels mean for sperm production prognosis? What treatment options exist, including HCG therapy? And then there's a second part to this after.
In the male, the higher the FSH is naturally, the more, so the pre-intervention FSH is a signal. And the signal is that the testicles don't work very well, right? Because your brain is trying to scream at the testicles to do stuff. And so the more they're screaming, that's kind of telling you that that's less that the FSH is working. So you ideally want to see a lower FSH. 70 is super high. Men's FSH and LHs both naturally kind of go up over time because their testicles are aging. And so their brain requires a stronger sort of signal to get the testicles to do stuff. Now, artificially increasing the FSH and LH can be a good thing, right? So at the baseline state, it's a signal. But if we intervene and pump out even more, we could use that to try and stimulate more either testosterone production through LH, which is HCG, HCG is basically LH in a bottle, or FSH, and you can also give recombinant FSH. Hard to get, very expensive, but you can do it. And so like the lower the FSH is, the more sort of room there might be some benefit to give people more FSH and LH, either with a pill like Clomid, which boosts both, or by injecting one or the other. The higher the FSH is, the worse the testicle likely is at default, and the less good you're necessarily going to do by giving it even more, right? So like, it's already super high, making it slightly more high, it's not going to be as big of a deal as when it's like here and then up. And then when it's really low, sometimes those guys are more just like pituitary hypofunction, and we can make a lot more impact that way.
And so, Dr. Sun, would you say like someone with the FSH of like 14, perhaps maybe try some of these medications that you just mentioned, but the FSH of 70, would you say, maybe a microtesty and cross your fingers and see what happens? What would you say in that scenario?
Yeah, I think let's just say they're both azoospermic. I can give either one, anastrozole or letrozole. I might give Clomid or something like that to the guy at like, the data shows it works best when it's like less than 6, but like, 10, 14, maybe. If it's already 70, Clomid's not going to do anything. FSH is not going to do anything. And I will be pretty blunt with them and tell them like, look, we can try a microtesty, but I'm not going to like pretend like I think there's a really high chance here. It's just that because I can never say 0, right? There's only very, very rare circumstances like ACFA or something. Because you can never say 0, you're always stuck saying something that's not 0. And, then because I hate to say like made up, but like most of these like probabilities, ultimately, they're a little bit of, individual interpretation. There's not like some normalgram that you can like plug in your data into and be like 17% chance. You can get closer. You can get ranges, but it's never going to be perfectly exact. And so, yes, I would say for the 70 guy, if he wants to, microtesty and cross your fingers. But, even that's a big determination of whether or not to pursue that. Right?
And Dr. Sun, you bring up a very important point. You can never say 0% or 100% on anything. And I know as healthcare providers, we struggle with that because we really want to help people and we want to like give them confidence, but at the same time, be realistic in terms of what we tell them. And this is so important. A lot of what you and I do is probability, and it's and I get it as myself, as someone who's done infertility treatments to have my only child. I get it. And it's hard as a person when you're putting in all this time, money, emotion, investment into this for a probability and a chance, and it's hard. But yes, this is super important that people understand that for both male and female infertility, there are probabilities, and there's no such thing as 0%, but sometimes it's pretty low chances.
Mm-hmm. And then Dr. Noorhasan, just to follow up on that and around this whole discussion around FSH levels and other levels, like what are from an IVF perspective, how should patients be navigating that, especially if maybe they've haven't had success after multiple cycles?
Right. So this gentleman with the FSH of 14 and the azoospermia, like Dr. Sun said, he would try medications, perhaps the microtesty. The gentleman with the FSH of 70, though, that's a significantly low chance of recovering sperm. And when these couples come and see me, I will say, okay, we're going to do IVF. Now, particularly if the female partner is 39, 40, we know she also has a low egg reserve just based on her age. We'll do IVF. And perhaps we have Dr. Sun do the microtesty that day, but also perhaps strongly consider having donor sperm as backup. And that's a bigger and more difficult conversation to have with folks. And sometimes they're ready for it, and sometimes they're not ready for perhaps having donor sperm as backup in case we don't get any sperm to fertilize the eggs from the microtesty. We have the donor sperm as backup, and we're going to utilize that sperm to fertilize the eggs. And that does take some time to get a couple to that point of where donor sperm may be necessary. We'll send them to a therapist, make sure they're comfortable with that process moving forward. But that does take some time, and coming to that conclusion, hey, we may need to do donor sperm as a backup in some scenarios.
Got it. I know I wanted to switch gears because there's been a few comments or questions around anti-sperm antibodies. Is that something that we want to delve into? The one that I was looking at right here was what, to start off on the basics around there and then dive into that. Dr. Noorhasan, do you want to start?
Yeah, so anti-sperm antibodies really come about from like a breakage in the barrier between the blood and the testes, and that's where the antibodies develop. Vitamins, antioxidants, great. Most of the times, though, they will do IUI. So IUI, you can wash the sperm, spin it down, get rid of all the other um, items that are in the ejaculated specimen, just get the sperm only, and then reconstitute the sperm in some media and utilize that for IUI. So you would be washing away many of the other factors that are in the semen sample, including the sperm antibodies. And then by doing an IUI, you bypass the cervical mucus, therefore as well decreasing the exposure. IVF with ICSI, intracytoplasmic sperm injection, is also another great way to do this because we completely wash the sperm and then we pick up a single sperm and inject it into a single egg to create the embryos, and really cut back on the exposure to anti-sperm antibodies, either with IUI or IVF and ICSI.
I completely agree that, whenever I see that, and usually someone like me is the cause, right? Vasectomies can do it, testicular trauma, testicular surgery, things like that. That can create these antibodies. They can cause them. Essentially, you can think about them as like clumping the sperm together. So what do sperm want to do? They want to swim freely. They have to get through the cervical mucus. So when they're all like clumped up, it may be hard to do that. It may be hard for them to get into the egg. But before like we had IUI and IVF, we would give people like steroids and stuff, but the downsides of that are much greater than the possible potential benefits of it. And so I usually direct those guys to, hey, if it's not that bad and like you still got tons of sperm, IUI takes care of most of the potential worries, right? You're getting past the cervical mucus, you're getting all the, as Dr. Noorhasan said, washing off all the crud and just getting what you want. And then if that doesn't work, or if, there's lots of like really interesting scientific nuances about anti-sperm antibodies. Do they attack the head? Do they attack the tail? Like, do they prevent capacitation and inability to get into these are all like cool things in the lab. But at the end of the day, if it's not achievable through IUI, then we just recommend IVF. And with ICSI, you can basically also bypass the last potential problem, which is getting into the egg, because you're getting it in there manually with like a microscopic pipette. So, yeah.
Man, there's just too many good questions coming in. All right.
We're going to have to do a second episode.
Yeah, I think so. I think 30 minutes really flew by right there. All right. I think what we'll do next is kind of log down these questions here, and then maybe we can go over them separately and see if there's any that we can respond to. But yeah, overall, I think we got through most of them, most of the big ones there. Thank you, both of you guys, for answering them. One thing I'm just wanted to end off with is what should people do next? Because a lot of the people that are on here are probably have been on their journey for some time. And what would you recommend if someone's been on it for about a year or two now and getting deep into the different tests and counseling and maybe multiple cycles? What do you recommend for patients like that, and as they find their cases are becoming more and more nuanced and unique?
I'll defer to Dr. Noorhasan. Luckily, in many ways, men are much simpler, emotionally, psychologically, physically. My job is to mostly get the sperm, and then I pass it off to people smarter than me. So, that you probably deal with a lot of like recurrent, losses and this kind of thing. I'll defer to you on that.
Yeah, I first thing is don't be scared. Go get tested. So if you're thinking about it, you've been trying for a long time to get pregnant, both you and your partner, go get tested. You want to know what you have to work with. And then you go back for your follow-up appointment when you get the testing results. And there may be treatment recommendations that you are not ready to hear as yet. But there's no harm in learning about yourself by getting the testing done and then learning what your options are. And then there are couples, like you mentioned, Thiv, that they may have been on this journey for quite some time. Talk to your doctor. I mean, do we need to do something different? If we're doing the same thing over and over and we're not getting the same results, perhaps we have to do something different. There are so many tools that Dr. Sun and I have in our toolbox that we can do to help you. And sometimes it may be something that you are not ready for. It's 2026, and in 2026 in the United States, becoming a parent can be a real possibility, whether it's natural conception, IUI, IVF, testicular sperm extraction, adoption. Becoming a parent can be something very possible. And I think following your heart and going through the testing and the treatments and knowing, hey, I've unturned this rock and this is what we found, and at least we know what we have to work with from this, and keep going, because parenthood is a real possibility.
Yeah, and I'll add to that on the male side. I think, fortunately, so there's two main types of patients that I would say that I treat. I treat guys who are azoospermic, and then I treat guys that are like, the sperm's mediocre. It's not a gazillion. Like, there's something not perfect with it, but it's there. I mean, that's really the big cutoff in my world, is like, are there sperm or are there not? Because if there are, then I can do more with it, right? But from a population level, it's interesting. Like, there have been some papers that come out, and even like popular media press about it, how like sperm counts are declining and testosterone levels are declining and all this, and it's all a reflection of the same fundamental truth, which is that healthy bodies make healthy sperm for the most part, right? Outside of genetic problems. Unhealthy bodies make unhealthy sperm. So the reason why the average testosterone level is declining is the same reason why the average sperm level is declining, because it's the average health span of people is declining, right? And if most people like just lost weight, exercised more, like all that kind of stuff, that would tackle a lot of like the sort of, oh, the motility is not that great and the morphology is not that great and that kind of thing in most patients. And so, yes, we have medications, we have like fancy surgeries that we can do, but much of it can be done before needing any of that, which is basically healthy bodies make healthy sperms. The testosterone is probably the single, if there was one lab you had to pick that would give you an overall insight into like the general health condition of a guy and likely his fertility as well, I would pick testosterone. But, and this is my concluding statement, do not take testosterone if you want to have kids, right? That's probably the number one, by far, most common cause of self-created infertility is taking testosterone. And nowadays it's super popular. You can buy it from like 50 different websites online and start injecting, and they're not really good about telling you that it kills your sperm. I can't tell you how many patients I see a week that's just like, I don't make sperm. And I look at them in their medication list. I'm like, you take testosterone, that's it, and then you have to go through a very painful like period where you have to come off for like a year and all this kind of stuff. So completely, like, if I get you to make more of your own tea with meds, or if you get yourself to make more testosterone through diet, exercise, weight loss, more sleep, less stress, all of that, sperm are happy. If you take outside testosterone, sperm die. So just remember that.
And I want to just say a few things. Dr. Sun is absolutely correct on so many aspects there. So for all of us, men and women, when we're younger in our 20s, our age compensates for a lot of our lifestyle factors. And as we advance in age, and now in our population, we're putting our career, doing other things, traveling the world. And when we finally get around to having kids, we're in our late 30s, early 40s. And so it all starts with that egg and sperm. And that egg and sperm is only as good as the person whose body it's inside of. And so it's the same way when in our 20s, you could study all night for an exam and be functional the next day. In our 30s and 40s, we cannot do that, where age doesn't compensate for some of our habits. So that's where our lifestyle is important. So healthy lifestyle, antioxidants, getting sleep. Sleep is super important. Just like how when we get a good night's rest, we wake up the next morning ready to function. It's the same thing that's happening on all the cells inside our body. Those cells, the ability of those cells to function correctly and efficiently depends on how much rest they can get as well. And that's the egg and the sperm cell are super important. So it starts with that egg and sperm and how healthy you are. The healthier both of you are, the healthier the egg and sperm will get. And he's right. Healthy lifestyle will improve your testosterone levels naturally. Healthy lifestyle, getting good sleep, a good reasonable amount of exercise, eating a nice balanced diet will improve your testosterone naturally. And then we can give you or Dr. Sun can give you medications to improve your testosterone that can help get that mediocre sperm to a little bit further up. And don't take testosterone replacement therapy. That's one of the biggest things we see. And sometimes I have couples where the husband started testosterone replacement therapy. They forgot to tell their wives and they forgot to tell me. And we get to the semen analysis and there's no sperm in the semen analysis. And I get it. Testosterone supplementation makes you feel good about you. It improves lean body muscle mass. It improves libido. It's not great if you want to have a baby, and there are better ways to naturally increase your natural testosterone. And then there's one more thing that Dr. Sun also said that I thought about is even getting small improvements in the sperm. Sometimes I send men to Dr. Sun and they come back and their sperm improved a little bit, but the guy's beating himself up. He's like, I thought it'd be completely normal. And it's okay if it's not completely normal. That small improvement in semen parameters sometimes makes a massive improvement on the embryo quality when we do the IVF, and will make a massive improvement in terms of the chances of that male's partner getting pregnant. So I would say don't beat yourself up if you have just a small improvement in the semen parameters, because those small improvements make massive improvements in what we see in the embryos. And it's really the addition of everything we just talked about in this session. It's the healthy lifestyle, getting good sperm. It's seeing your physician, doing well with the IVF, getting good embryos. It's the addition of all what seems to be small, minute changes in our lifestyle and our day-to-day function can make a massive improvement in terms of our embryos and in terms of the ultimate goal is take home baby rate of having a baby to take home. And that's super important.
Awesome. And if people want to reach out or learn more about you guys or actually have a consult, what can they do? How can they reach out?
Yeah, definitely. You could just Google my name and the websites come up immediately. We have our phone number on there, our address. I'm in the Dallas-Fort Worth area. I do telehealth as well with people who don't live nearby. So a lot of people will choose to do their consultation via telehealth and then come in for the actual procedures. So that can be arranged as well. There are parts of our country where access to care is not where it should be. And so providing telehealth has been important for me to be able to reach patients further out from the DFW area, and then just having them come in for the procedures.
Yep, same thing. Practices in Arlington, if you Google my name, you'll either see the practice website or my website. But we also do telehealth. A lot of the fertility stuff is talking and looking at numbers. Is it nice to do an exam once? Yes, but if you have the numbers and everything, that you kind of have an idea of what's going on. So happy to help anybody who wants.
Oh, that's great. You have the websites up. I love it. Thank you, Thiv.
No problem. Well, thank you both for taking the time. I know you guys have busy schedules. We got through as many questions as we can. This was a lot of fun. And so I really thank you for taking the time.
Thank you all.
Thanks, everyone. Take care.
All right. Thanks, everyone.